Thank you so much. So I'm a little nervous, so I need some support here. So can you guys say good morning? Thank you. So I'm really honored to be here today. Thank you to the Hint team for letting me come talk today. I'll try not to shake too much. I'm honored to be speaking after Garrison and before Erica. For those of you in this field, they are our pioneers and our inspiration. And it was seeing them in Time Magazine in 2014 that really legitimized my path towards DPC. At that time, people were telling me this wouldn't work, and they were wrong. And if someone's in Time Magazine, then it has to be good, right? And Erica is a true inspiration with her pioneering efforts to work through larger systems and government systems and try to make this work. And the lessons she learned are going to be valuable for all of us. And Erica had the grace and kindness to talk to me, someone she didn't know, when I was getting started, when she was in the midst of all of her work and her busy life. Ken Richter, who was sitting here, has this amazing video he did, which it exemplifies the absurdities of our insurance-based healthcare based on a restaurant experience. And so if any of you guys can go and ask Ken for access to this video, it's perfect. So I just want to give credo to all of the people on this stage. My name's Emilie Scott. I'm a family physician. I've been in practice for about 12 years. My husband and I, like Mike said, we have our DPC called Halcyon Health in Irvine, California, not too far from here. And we've been in operation since March of 2016. Before having my DPC, I worked for a large HMO group healthcare. And prior to that, I worked in an academic center. So all of us decide to become physicians for different reasons. For many of us, we're wanting to make our parents proud. Some of us are really interested in the power and prestige of being a doctor. Others of us, we like the idea of having the security of a valuable skill, some way to make money for our lifetime. It feels comforting. Other people are really enthralled by the science and engaged and interested in learning more about the human body. But for many of us, we have altruistic intentions. We're really fulfilled by helping other people. And we get a lot out of connecting with our fellow humans. No matter what set us out on our path to become physicians, we all end up here, face to face with a patient who's looking to us for help, for guidance, and support. And they're vulnerable. People come to us and they tell us things they don't tell their closest friends or their family members. They come to us and talk about their bowel movements and their orgasms. They cry. They look to us for support when they're vulnerable. And no matter what set us on this path, even if it was for power or prestige or just to make a lot of money, we still end up here, and we feel it. We all feel it. See, I gotta look at my notes because I'm nervous. So thanks, guys. Thank you. So in my medical school, there was a quote inscribed on the entrance to the lecture hall, and I wanted to put this quote up here so bad, but apparently they've remodeled the building, so time flies. But the sentiment of the quote was, "There's no greater honor than to be entrusted with the welfare of our fellow humans." And this had such an effect on me. And as I advance in my career, it is the greatest honor. It is the best part about what we do. So how does insurance pay us to rise to this veritable honor of caring for our fellow humans? Any of you who have practiced in an insurance-based model might see this alphabet soup and have a visceral reaction, because we all know what it means. So nervous. I'm going to hold it. We are caught between so many good intentions, which many times are poorly executed, and get between us and our higher mission. So let me break this down for you. I got this. So let's say you're in your practice, and you have this gentleman come in. He's a 50-year-old man. You've never seen him before, and he's having chest pain. His best friend just died from a heart attack. He's grieving the loss of his best friend. He's anxious and scared, and he's embarrassed that you're going to think he's a hypochondriac because he's talking about his chest pain. And so, as a physician, there are so many layers to this interaction. You have to make sure this man isn't going to die from a heart attack, But you also need to address his grief and his anxiety, and you need to make him comfortable so he can open up to you and tell you what he's really feeling. If he holds back, you might miss something. So here you are in your practice. You're an hour behind because of some of the things Garrison alluded to. You have tons of people waiting for you. He's sitting here crying in front of you. You have this electronic medical record in front of you, right? It's fuzzy on purpose, right? Some of us might call this an electronic billing record, right? There's a bunch of checkboxes. So you're trying to get through your checkboxes. You're furiously clicking on your mouse. And you're going through your long list of ICD-10 codes and pay-for-performance measures and trying to make sure you do everything you can to stay on time and to make sure that your group or your private practice stays afloat. And here's this man crying in front of you. You know, one thing, people don't talk in checkboxes. These systems are not designed for patient care. So you can do a couple things. You could ignore all the people waiting, and you could focus on this man, and you could listen to him, and you could connect to him. And maybe if you did that, you would find out that his chest pain actually is it's abdominal pain, and he just needs an antacid. And so you've connected with your fellow human, and what they say about doctor burnout is that doctors who connect to their patients have less burnout. So if you've connected to him, you feel like you've done a better job, and you probably have. But if you did that, now you've left the waiting room a little more crowded, and you've disappointed your administrators, or you've put more financial strain on your practice because you didn't get to your check boxes. Either that, or when you get home, you're spending 5 hours trying to make up for what you did by doing a good job at work. Alternatively, you could go through the check boxes, right? You could say, okay, I've got 5 minutes with you. Let's do this fast. Okay, what you got? I'm going to go through my list. I'm going to order some tests because tests buy me time. And tests actually make money. So let's get an EKG real quick here. And then maybe I'll have a few more minutes to see the 10 patients in between, right? Maybe I'm just going to refer you quickly to a cardiologist because that's a lot faster, and that actually covers me. Right? If I miss something, well, I referred you to the cardiologist, and so. But now I haven't had a chance to connect with this guy. He's crying, and I'm like resenting him because I'm in a hurry. That's not good, and that leaves me feeling kind of like an asshole. It leaves us spending more healthcare dollars because we've done all these extra tests that had I had more time to listen to him, I wouldn't have done. So as you can see with this example, there's no way to win. We're just pulled in so many directions. In my prior iteration in a large group practice, there was a big push to get more revenue from Medicare Advantage patients. And many of you, I'm sure, know this, but Medicare Advantage pays more money for sicker people. Good intentions, right? It makes sense. You should get paid more if you're caring for the gentleman who has diabetes, kidney disease, and multiple myeloma than you do caring for the man who has nothing and plays tennis. So good intentions. But here's how it plays out. Our group, in order to increase this revenue, put a significant amount of resources into finding codes. And the way to do this was to go look back in the charts. And if someone had calcifications in their arteries on a chest x-ray that they had done years ago for another reason, they were coughing, then this might help us be able to code for them having atherosclerosis. And if they have atherosclerosis, we should get paid more to take care of them. But if they have atherosclerosis as an incidental finding on a chest x-ray, what am I going to do differently, right? That's not a reason to change their medical management if that's the only thing, right? We might look at things, we might talk about health in general, but we should be doing that anyway. And so many resources were put into this. Resources were put into doing extra testing for patients. Patients were, we were basically told if we don't want to do these extra tests, we could work somewhere else. And so here we were in this system trying to make it work. Good intentions, poorly executed. So let me tell you about Alice, not her real name. Alice is a patient of mine that I've known for many years. She has a deep mistrust of our healthcare system. Her husband died from complications of a colonoscopy, and she was at one point prescribed the wrong medication and had some consequences from that. and she had anxiety. And she had said to me, Emilie, I do not want any extra tests. If it's not necessary, I don't want it. And we had known each other for so long, and she trusted me, and I really honored and valued her trust. I'm sure you guys can see where this is going. So the workflow in our office was the medical assistant would take a patient back into the room. If they were a Medicare Advantage patient, they would be offered these extra tests, and these tests would be performed. Tests, pulmonary function tests to test their lung function, blood flow tests to make sure the blood was flowing. Sounds good. And so Alice was a Medicare Advantage patient. So she was brought back into the room, told that I wanted these tests done, and had the test performed. And so when I went to see her, she was in tears with anxiety and panic. These tests brought up a lot for her. And she looked at me and she said, you know, Emilie, I did these tests because I trust you, and you ordered these tests. And so this is what it's like. This is what it feels like. This is why so many physicians are burned out. Because we are given trust, and then that trust is dissolved by the system outside of us. And we feel there's nothing we can do about it. We're caught between these good intentions that are poorly executed. It's no one person's fault. We're all trying to figure out how to make it work, but it's not working. Doctors are not burned out because they need to do more yoga classes or more courses on wellness and work-life balance. Doctors are not afraid of hard work. We work hard. We volunteered to go to medical school, right? We're not afraid to work hard. But what we don't do okay with is constantly being put in a situation where our patients' trust is being undermined by things we can't control. Okay. So how can we do things better? How can we make a system that works? I was trying so hard because I was scared to go off on my own. I didn't want to go and have my patients pay me outside of their insurance, right? They needed to use their insurance. So what about group visits? Maybe we can have everybody come in as a group, and that might free up more time. That didn't work. During the group visits, we were looking for codes and documentation. It was a dance. And then afterwards, I was still overwhelmed. What about stratifying the care? The medical assistant will do all the upfront work. The PA will see the less sick patients, and I'll see the more complex patient. That didn't work either. I was still overwhelmed with many complex patients, and the patients I had built rapport and trust with, they were gone. They were gone to urgent care. I didn't know what was going on with them. And then I started reading what Dave Chase had written, from what he had learned about what Garrison's been doing, about direct primary care, about this model that connected the incentives, that aligned the values of patients with the values of physicians. Coming back to you guys. This was the only model that made sense to me. Alice needed someone who would spend more time with her in the office and get to know her and build her trust and talk to her about other alternatives for colon cancer screening. She didn't need someone to bombard her with tests she didn't understand, further undermining her trust in the system and pushing her farther away from reaching her goals. The only way that this works is to align incentives. Patients need to have the power. They need to feel empowered by their healthcare team. The idea that patients can pay you month to month means that if patients are not happy with your care, then they can leave. The other thing it means is that if you don't want to do the wrong thing for your patients, they can also leave. There's tremendous power in that. Now I can decide how much time my patients really need. My 97-year-old, who takes an hour to walk in the door and get to his seat, who's more complex, I'm going to give him a lot more time than my 50-year-old business CEO who just needs 5 minutes with me on the phone. My mom of 5 kids, one who has pneumonia, we can get her in the office, diagnose her child, and get her antibiotics and out the door. And she doesn't have to stop at the pharmacy. My 40-year-old who broke his ankle, I can order an x-ray, get him in for $40 for an image. We can go online and consult an orthopedic surgeon and order a boot for him on Amazon and get him all cared for at a fraction of the healthcare cost. We have a panel of about 850 patients now. We see 8 patients in the office daily on average. We touch and interact with about 50 to 60 patients per day through our medical system. My time's up. I'm so quick, I'm going to finish it. Through our system with texting and messaging. We reach out to our patients in between visits to check their blood pressure, to talk to about managing their blood pressure and their diabetes. Healthcare happens outside the office. I get to listen to my patients. I get to streamline visits that should be streamlined. If you have a quick question about your cough or cold, you don't have to drive to the office to see me. I know you. We can talk on the phone. If this is the 5th cough cold episode you've had in the past 6 months, I know we need to dig deeper. This is something that you may not get from telehealth or urgent care. I'm working very hard for my patients, but I feel like I'm doing the right thing now, and it feels right. I'm really almost done. As with anything, there's no perfection. This brings up problems that we've all deeply considered in the healthcare system. How do you define and enforce quality care? What does that even really mean? Colon cancer screening saves lives. We know this. We should be offering the best of our healthcare to all our patients. If you're 50, you should have colon cancer screening done. Maybe 45 now. But let's say you have a doctor who thinks colon cancer screening is stupid, that we shouldn't do it at all. Should that doctor be supported? What should we do about that? What about the doctor who's caring for Alice? And Alice needs more time to get her colonoscopy or her colon cancer screening done. Should that doctor be punished? I don't have the answers. What about the question that we have more patients, oh, she's waving the flag. We have more patients in our panel when we're under insurance-based care than direct primary care. And the answer I have to that is when you're an insurance-based practice, you're not really caring for 2,500 patients. Our patients are going to urgent care. They're going through telehealth. They're using other resources because we can't manage them. When our patients call our office, it's a whole different thing. We know who they are. We know how to talk to them. I don't know how you create that on a bigger scale. But I'm very optimistic that this group will figure it out with people like Zach in the room and Sean Shanson and Rob Lamberts and all of these people who have set the tone for this. I'm so excited to work with you all, and thank you for letting me go over.